I want to thank Dr. Lawton for having me. I think this is the fourth, fifth, sixth talk that I've done. So every couple years he asks me, and I really enjoy doing these. So I haven't done this one before. This is the first time that he's asked me to talk about abdominal pain. So a little bit about myself. He mentioned I've been in the community here working for 17 years. I practice internal medicine. I'm married. I have 3 kids. I have an 18-year-old, a 16-year-old, and a 14-year-old. So they keep us busy for sure. And so tonight, what I'm going to do, the way I'm going to approach this is I'm going to let you guys know how I deal with abdominal pain on the outpatient setting. So I'm an outpatient internal medicine, which is very different than how maybe an emergency room would handle abdominal pain. There's different settings. So we're going to focus on the presentation of outpatient abdominal pain. Abdominal pain is a huge topic, huge. The number of different things that can present as abdominal pain is almost endless. So I came up with a quick list. So I kind of threw these up. Some of them I looked up, some of them were out of my head. But the question is, when a patient comes and sees me and they're presenting with abdominal pain, their main complaint is abdominal pain, how do I, as a physician, take all of these potential diagnoses that we read about in medical school and learn in residency and dwindle that down to a reasonable number of potential diagnoses, which will then guide our imaging. And so the key to doing this, I learned from when I was in medical school. I rotated with a rheumatologist in our office who recently retired. Did anyone know Dr. Michael Fabricant? Yeah, okay, so Dr. Fabricant was great. And so I remember shadowing him and watching him examine his rheumatology patients, and he would spend a lot of time talking to the patient about what their main complaint was, so for an initial consultation. And afterwards, he told me, he said, the 3 most important things about your visit with the patient in terms of coming up with a diagnosis, the 3 most important are the history, and the history. And I never forgot that. And so I utilize that, but for something like abdominal pain, I think it really is true. So when I'm seeing someone come in, what I'm thinking is, I'm asking all of the different questions I can think of that's going to take this huge list and narrow it down. So, how long have you had your pain? Where is your pain? What's the quality of your pain? Does it feel like someone's sticking a knife in you? Is it dull? Does it feel like a muscle ache? Does it go anywhere? What position can you put yourself in to make your pain better? What makes your pain worse? Does food make it better? Does food make it worse? Is it constant? Does it come and go? Have you ever had it before? It goes on and on and on and on. But that's kind of the approach. Really asking detailed questions to get this list down to a more reasonable number. The other thing we think about, and this is really important in internal medicine, in medicine in general, is on that list there was maybe 100 things that were listed. There's maybe 10 that we see a lot. So what they taught us in medical school is when you hear hoofbeats, think of horses, don't look for zebras. So zebras are the rare diagnoses. And common things happen frequently. And uncommon diseases are uncommon because they don't happen a lot. So when I have medical students rotating with me and a patient comes in and let's say they're presenting with abdominal pain and they take the history, I'll say, what do you think they have? They might say, oh, they have familial Mediterranean fever. And I'll say, no, they have gas. That's what we're dealing with here. But so really kind of thinking about what presents commonly, always keep those at the top of my mind, and really, really, really getting a good history. Okay, so after that's done, we get into what Dr. Lawton talked about, which is the examination. So part of the history, though, I talked about location. For abdominal pain, location is really, really important, because the location of the abdominal pain kind of correlates with our anatomy. So this actually has 9 regions, but really we think of right upper quadrant, left upper quadrant, left lower quadrant, right lower quadrant, and epigastric, which is kind of right in the center. Maybe suprapubic too, which is kind of bladder. So right upper quadrant, gallbladder, liver are the 2 main things that we're thinking about in that area. Left upper quadrant is the spleen, which is not something that commonly, unless there's trauma, is something that causes a lot of abdominal pain. Left lower quadrant is the descending part of the colon. So something like diverticulitis is something we see a lot. Right lower quadrant is your appendix. That's the main one in that area. And then the suprapubic region is bladder. We think bladder, or for females, a lot of their gynecological organs. For men, the prostate, if it's inflamed, can cause kind of suprapubic discomfort. Epigastric pain, so right through here is stomach, and then behind the stomach is the pancreas. So this is kind of going to give us our landmarks of what we're thinking about with abdominal pain. And then the examination. So the abdominal examination is critical. And when we're palpating the abdomen, there's a few things that we're looking for that really are going to get our attention. And we're looking for something really, initially, something called a surgical abdomen. And that is when we palpate the abdomen, we feel the patient involuntarily tighten up their abdomen because of the discomfort. We can't palpate deeply. They're guarding, we call it. And the other thing is, when we press down on the abdomen and release our hand, if that releasing causes a lot of pain, that's a sign that the lining over the abdomen, the peritoneum, is inflamed. And that can be a sign of a really significant infection. So always, getting your hands on the patient, feeling the temperature of the abdomen, visually just looking at the skin of the abdomen. So another residency story is we had a patient in our outpatient clinic presenting with back pain. People were figuring out what's the pain? Did they pull a muscle? Is it a bulging disc? Is it a pinched nerve? And not until the attending, none of the students, but the attending looked up the shirt, and the patient had a linear rash. It was shingles. So you have to examine the patients. So hugely important. Okay, so what we're going to do is I'm going to go through a couple common presentations of abdominal pain. I'm thinking to do maybe 2 or 3. But I think this was a good way to do it, because as we go through this, you'll see the thought process, how we kind of narrow down. And then once we figure out what it is, we can talk about, is imaging necessary, what type of imaging to do, etc. Okay, first case. 44-year-old female, pain on the RUQ is right upper quadrant, intermittent, so it's coming and going. And when she has the pain, it's 8 out of 10. So let's talk about pain scale. This is important. When physicians ask you, when you're having pain, how much pain are you in on a 1 to 10? I sometimes laugh because a lot of my patients say it's 10 out of 10. I have 10 out of 10 pain. And I think what they're trying to relay to me is that, take me seriously, I have pain. But from a physician standpoint, the pain scale, we're not going to neglect your pain if you tell us it's a 4 out of 10 or a 5 out of 10. It's actually going to help us figure out what's going on. 10 out of 10 pain, if you think about it, if 10's the highest and it's 10 out of 10, there's nothing I can do to make your pain worse. I could take a toothpick and put it in your eye and it wouldn't make it any worse because you're already 10 out of 10. So if you're sitting comfortably in my exam room, it's not 10 out of 10. So, so having a realistic discussion of the pain. But 8 out of 10s, that's pretty significant pain. That's very, very uncomfortable pain. 8 out of 10, you would probably have a hard time sitting still. You'd probably have a hard time having a normal conversation. This is good pain. Okay, so just with this initial information, this wouldn't be obviously the whole history, but it's a 44-year-old female. It's right upper quadrant. It comes and goes. It's pretty intense when they have it. So we started with this crazy list. From that little information, I can dwindle it down. This is what kind of, it happens, it just happens. We just kind of are always doing this. Okay, a few more questions. Yeah. It started a few weeks ago. Worse after, not just worse after a meal, but particularly worse after something fatty. The duration of it, so it's about an hour or two, and then it kind of settles down. And throughout these 2 weeks, she's not having any fevers. That's really important. So fevers to us, we think about infections primarily. And when the attacks go away, she's pretty much normal. Okay, getting closer. So now we had this one. We're pretty much down to here. I'm not going to go through all these. This is more just an example of kind of how we narrow it down. And then a few more things. She hasn't been losing weight. She tries to take Tums or antacids, over-the-counter stuff, when she's having an attack, and it really doesn't do anything. Once in a while, she'll notice during attack or shortly after that her urine changes color. And when she's here in the office and I do the exam, it's completely normal. It is a normal exam. She's not in pain. I really poke up into the right upper quadrant. I don't feel anything concerning. So with that history, what do we think? Anyone got an? So we were that. Now, basically, I'm really, really, really focusing on the gallbladder. I know there's something going on with the gallbladder. What the gallbladder does is after you have a fatty meal, it squeezes, it pushes bile, and it meets the food that's coming through the stomach into the first part of the intestine, and it helps digest it. So a fatty meal triggers a gallbladder to do its thing. So if you're having discomfort after a fatty meal, that's a really indicative sign that something might be going on with the gallbladder. So with that in mind, when we're thinking gallbladder, there is one imaging study that is by far the one we start with. You guys know what it is for a gallbladder? What imaging? Yeah, an ultrasound. Ultrasound, for sure. So what test? The ultrasound. So this is a picture of the ultrasound, and what you'll see, these right here are stones. And this here is the shadow that's made from the stones. This is the liver, these are the stones. Remember, gallstones, just having gallstones is really common. A lot of people have gallstones and don't know about it. They don't always cause symptoms. So you have to match the symptoms with the findings on the ultrasound. When someone's having gallstones and they're having attacks, like we think this lady is, you won't just see stones. The lining of the gallbladder from contracting against a stone that gets stuck gets thick. So the radiologist will read it in the report and they'll say, there are gallstones and there's a thickened gallbladder wall. And then the gallstone attaches through a small little duct, and if the stone gets stuck there, then that duct gets swollen too, the common bile duct it's called. And so they'll report that. So with that presentation, if we get an ultrasound and there's gallstones and a thickened wall and that dilated duct, this lady's having gallstone attacks. And the treatment for that is what? Surgery. Right. All right. So 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 the ultrasound, when we're thinking about gallbladder and liver, is the best test. You know, we love ultrasounds because they're inexpensive, they're harmless. They don't penetrate the skin, there's no radiation, they're easy to do, and you get a lot of beneficial information from them. And what I'll do is, I think I'm going to go through my talk, which is not very long, and then we'll leave time for questions. So if you have questions, remember, and at the end, we can go through them. Okay. First one was a woman, this one's a male. 57-year-old male. For 4 days he's had pain. Now this one's on the left side. So left lower quadrant. He is having some fevers, and malaise just meaning he doesn't feel well. Okay, so let me start with that. Bowels are not as regular as they normally are. Oh, I heard it already. And the left lower quadrant, you know, when we do the examination, there's some tenderness there. I mentioned, remember we talked about the surgical abdomen? There's none of that. He's tender, but not guarding. It's not rigid. There's no rebound. So I mentioned when we talked about the quadrants, the left lower quadrant, there's not a lot there. There's really just the descending colon. So this patient has diverticulitis. Okay. Very, very, very common. So when I see diverticulitis in the office, you do not need, if I see a patient that is like this, stable, you know, walked in themselves, is able to eat and drink, but is sick, and I think they have diverticulitis, and I'm pretty confident based on the history and the examination, I won't order any imaging. I'll treat it. So it's okay to treat certain patients just with, we treat this with antibiotics. We usually give 2 different antibiotics for it. You don't have to do an imaging study. And I think this is the differentiation between outpatient medicine and the emergency room. Because I promise you, if you present to the emergency room with a low-grade fever and abdominal pain, you are going to get a CT scan. If you present to the emergency room almost with any type of abdominal pain, you're going to get a CT scan of the abdomen. The job of the emergency room physician is thinking, this is an emergency room. I am not going to miss a catastrophic problem. They see really serious things. So their thought is, rule out the most important things, and once I've done that, they can follow up with their primary care doctor or whoever. So they're going to get a CT scan. In my setting, it's different. I know my patients well. I understand the pace of illness. And remember that CT scans are not innocuous. They have radiation. So a CT scan, just so you guys know, has about 80 times the radiation as a regular chest X-ray does. And so it's cumulative, and there are different issues that leads to. And the other thing is, when we get, the imaging nowadays is so detailed that when they do CT scans, they inevitably see things that we were not intending to find. Spots on the liver, a lymph node that might be a little bit bigger than it should be. And we had no intention for looking for that, but here it is. And so unless you're ordering a test with a very specific purpose that's indicated, you're opening up yourself to different things that now require potentially other testing. So if you're too liberal on your ordering of these tests, this is kind of tricky to understand, but if you order unnecessary testing, you actually end up harming your patients more than you help. So if a healthy person comes in for a physical examination and I say, yeah, you look great, but I want to make sure you don't have a random cancer, I'm going to get a CT scan. That's horrible medicine. Not for the cost of it, it's costly, but because if I do that to all my patients, they're going to end up having more problems than if I didn't. I'm going to cause more problems because of the potential unnecessary biopsies, which could lead to infections, which could lead to bleeding, and all the different things. So it's super, super important to be judicious about what you order. Very, very important. I think it takes a little bit of experience. It takes a lot of experience. Younger physicians don't want to miss things. And they want reassurance that their diagnosis based on their history and physical was correct. They want to see that on the CT scan. But after you've done that a few times, you kind of realize you know what's what. And so that was a long story. But basically, for a healthy patient that's presenting with classic diverticulitis, it's 2 antibiotics, Cipro and Flagyl, and no imaging. We went over the test. So this is a CT scan. So imagine this view here. This is the back. They're lying on their back. There's a slice this way looking up. So this is their abdomen. This is their spine. And this is the colon. And this thick, thick, thick swollen wall here is the wall of the colon. It should be thin. So that's showing the colon inflammation. And typically with the oral antibiotics, we see over even 3 or 4 days a significant improvement. We typically tell them also to have a very bland diet. And we watch for things. You know, if after starting an antibiotic we have a sudden increase in pain, that's a concern. Fevers aren't going away, not able to keep down fluids, etc. Okay, you guys ready for another?
Yeah.
All right.
Getting closer,
Okay,
age-wise.
that's right. So 76-year-old female, and this patient 2 or 3 weeks ago had an orthopedic surgery. They had a hip replacement. And maybe for the last 7 days or so, just not feeling well, kind of very mild, not sharp abdominal pain, mild. 2 out of 10. They gave a good scale. They didn't say 10 out of 10. Because of the hip replacement, they've been taking pain medication. Now that might blunt their abdominal pain a little bit, but I think it's important in this scenario. It's a clue. Not feeling great, a little nauseated. They're not throwing up. Their bowel movements aren't great. They're having some, but they're not as regular as they normally are. Maybe a little small, hard movements. Who knows where I'm going with this?
Constipated.
Yeah. So when we palpate this patient, nothing specific, generalized discomfort kind of throughout the abdomen. Maybe a little bit in the left lower quadrant, a little more fullness. Constipation. So we see constipation a lot. And the key to constipation is when you think of constipation, you can be having movements and still be constipated. And the way to think about that is if you're creating more stool than you're eliminating, even though you're eliminating, it's going to build up. So this patient, after these surgeries, they take the pain medications, hydrocodone. They are incredibly constipating. They're great for pain, but they're incredibly constipating. And so this is a really common scenario that I see in the outpatient setting. And it can be tricky to know exactly what's going on. This is someone that just had surgery, so you're not quite sure. There's nothing too major on the exam. What I like to do for these patients is what test? Has anyone been in this scenario? What would we order for this?
Flat plate of the abdomen.
A what?
Flat plate.
Oh, that is exactly right. Yeah, a plain flat plate X-ray. We call it a kidney, ureter, bladder of the abdomen. And what it shows is it shows stool. So the dark part here is actually air in the colon. That's okay. I don't know if you guys can see it, but there's these little dark flex going all the way through here. This is all stool. So the entire, so not just the rectum, but the whole descending colon all the way up here and starting to come over is full of stool. Full of stool. So yeah, it makes you nauseated, you lose your appetite. It's a horrible feeling. So very important after surgery to wean off those medications. So this type of patient, we would try all the different tricks we have to relieve the constipation. But we see this quite a bit. Okay, so when it comes to imaging, I think I kind of covered the main point I wanted to make, which was if we feel confident about a diagnosis based on our history and our exam, we don't do imaging. Imaging should be when it's going to affect our treatment, when we think that there's too many possibilities or there are red flags or something that we really don't want to miss. So an infectious process like an abscess or something more acute, we would do the imaging. But when you think about imaging for the abdomen, it's ultrasound, which is right upper quadrant, typically gallbladder, the CT scan, the plain X-ray, and MRI. Now, MRI I very, very rarely will order it, and if I do, it's almost never on the initial presentation. That might be something further along when we've really narrowed things down, but never initially. And I talked about the main objective. So when I see patients, I want to keep them healthy. Like my goal is to do no harm, is to really keep them healthy. And ordering the excessive testing, specifically the CT scans, I'm not necessarily doing my patients a favor by doing that. So that's kind of the approach that I like to take. I mentioned this before about the amount of radiation that you get from a CT scan. It's really significant. And the younger you start with getting these CT scans, the more time you have for the adverse effects of the excessive radiation to take effect. So this is a little bit hard to read, but these are some of the more serious but also frequent presentations of abdominal pain. And this slide, which they'll probably make available to you guys, tells you what the recommended approach is. So we talked about the gallstones. So ultrasound of the abdomen is a treatment of choice. We talked about diverticulitis. Now it's saying CT scan, but look what it says to the right. Patients with typical symptoms and no suspected complications may not require imaging. And that's really the key. And I think down here they also have constipation. Let's see. Maybe not. But constipation would be the plain X-ray. So up here you'll see some more really kind of serious diagnoses. Ectopic pregnancies, acute pancreatitis. For something like a gastroenteritis, that's a perfect example of someone comes in with, which we're seeing actually a lot right now. Not only is the flu going around, there's a stomach bug right now that's causing real significant vomiting and prolonged diarrhea. It's a viral gastroenteritis, so there's supportive treatment. It's really all you can do. But it doesn't require imaging. It's symptomatic treatment. Urinary tract infections, really common. We see that all the time. No imaging required. Muscle strain. Muscle strain for abdominal pain is something that presents really commonly. The key when we're talking to patients about muscle pain is it's a positional pain. This is actually true for muscular pain in the back as well. Patients can often get themselves in a very comfortable position and have no pain, but with the right type of movement, they start feeling the pain. Same with the back. So talking to them about that, and when I hear that and I start thinking muscle, I always ask, what did you do about 2 days ago? It's usually something that an activity they did a couple days ago that wasn't in their normal routine. They started a new exercise class, or they were babysitting their grandchild and holding the grandchild, and they don't usually do that. And you can usually figure it out, because this type of muscular pain never starts right away. There's a delay. Like if you go to the gym and you do a hard workout, you're sore the next day or the day after, not immediately after. So that's kind of the approach for muscular pain. So that is a brief approach to how we deal with abdominal pain from an outpatient setting. I know I didn't go into a lot of the more complicated diagnoses because we don't see them that much. We see the simple, straightforward presentations. And so I hope you guys got an idea of how the primary care doctor thinks about it, how important the history is, the hands-on physical, and then the decision making on when to order or not order the imaging studies. Anything else?
Okay, thank you very much.
Yeah, welcome.